my name's Ed. I'm a intercalating medical student in Crick Care. So I've been based in the Royal Stoke Intensive Care Unit up until the COVID pandemic kicked off. My disclaimer is much the same as James. I'm going to be covering a lot today, and it might seem that at some points it gets very ICU-ish. So bear with me, because actually, even though these principles are predominantly ICU principles, there's a lot of applications outside the ICU. And actually, you will all see patients who are ICU patients, whether that's before they go to ICU or afterwards. And that understanding a bit about what's happened in between is quite handy. And as you can see, this is version 3. I made my first version 2 weeks ago, and everything, well, not everything, but a lot of things have changed. So I've tried to keep this as up to date as possible, but it might be the case that some of the things I'm saying are not up to date when you get around to listening, if you're listening on YouTube. Okay, so advanced respiratory therapies. We'll start by talking about advanced respiratory therapies. We'll then talk a bit about COVID specifically, and then we'll talk about ICU to finish. So, high flow nasal cannulas. So, high flow nasal cannulas provide heated and humidified oxygen at a flow rate greater than the flow rate that you breathe in. So, a lot of the interventions that James talked about, the flow rate that they provide is a lot less than we would breathe in. So, we breathe in about 20 litres per minute normally, but in critical illness that can be higher. In high flow nasal cannula, the idea is to provide greater than what you're breathing in, so you can go up to a flow rate of about 60 litres per minute. And why is that a good idea? Well, what it does is it basically flushes out the dead space. So you flush out all the air that you're breathing out. So when you breathe out, the oxygen in the air that you breathe out is low, and it's quite high in carbon dioxide. If you're putting high flow oxygen into your mouth, then it's going to flush out all of that air that you breathe in, and you'll likely be breathing in a lot higher concentration of oxygen. It also provides a degree of PEEP. We'll talk about what PEEP is in just a second, but it's worth knowing that that PEEP is very variable, depending on the flow rate, depending on whether or not your mouth is open or closed. There is concerns about it being an aerosol generating procedure, because obviously you're blowing in a lot of air into someone's mouth, and that could potentially lead to viruses being aerosolized. It also uses a lot of oxygen. So if you think about a flow rate of 60 litres per minute, and you are using an FiO2 of 1, so if you used 100% oxygen at 60 litres per minute, what you're going to find is that you could get through a standard oxygen cylinder in 7 minutes. So you can imagine in a pandemic, when you've got a lot of people who are requiring oxygen, you could quickly run out of oxygen in a hospital. So that's one of the reasons that that some places aren't advocating high flow nasal cannula. So CPAP, we've mentioned it briefly in our Q&A, but it stands for continuous positive airway pressure. And what CPAP does is it delivers PEEP. So PEEP is a constant pressure, as you can see by the graph on the right. So you can see the pressure on one side and the time on the other, and that constant pressure is what we know as PEEP. There's lots of different masks for CPAP, so you can see one that's covering the mouth and the nose, and you can see one here that's covering the entire face. And I like this picture because the patient's doing what a lot of people do when they have CPAP applied, which is trying to take it off, because it's a really disconcerting experience if you've ever been on the receiving end of a CPAP. So it's really important with these patients to communicate to them that it might be quite an uncomfortable experience, but that's what you should, quite an unnerving and unusual experience, and that's what you should try and communicate to them, that they will feel like that. So I'm not going to spend too long labouring the point here, but it probably is worth just revising a bit about ARDS. So what is ARDS? It's non-cardiogenic pulmonary edema. So let's break that down. Non-cardiogenic, it's not caused by the heart. Pulmonary, lungs, edema, fluid. So it's fluid in the lungs that's not due to the heart. And this is due to leaky capillaries. So why does that happen? So in leaky capillaries, you can get interstitial edema around the alveoli, so you can get fluid all the way around the alveoli, and that's a problem because it wants to collapse the alveoli. You also, in COVID-19, it's affecting type 2 pneumocytes, so that's producing a lack of surfactant. And the surfactant is a chemical that tries to stop the alveoli collapsing due to surface tension. So you can see all of these factors are acting together to collapse the alveoli. So why is that a problem? So I want you to imagine blowing up a balloon. The first breath is always the hardest part of breathing, and you can blowing up a balloon. And you can imagine the same is happening in the alveoli. The first thing that, in order to blow up the alveoli, you need to use a lot of energy, and that can cause people getting tired very quickly. So PEEP is a constant pressure being blown into the lungs to stop the alveoli from collapsing in expiration, and that's what we call splinting. And what PEEP does is it prevents de-recruitment of alveoli. PEEP also has the advantage of reducing the leakage out of capillaries and reducing the edema as well. It's worth noting that CPAP is aerosol generating, and as you can see by my hastily drawn diagram in the middle, that is, the grey arrows are what's meant to represent PEEP. So BiPAP is where you give not just PEEP, but you get an inspiratory pressure. So you detect that the patient is trying to take a breath, and then you give some pressure when they are breathing in. It's much the same in terms of you need a tight-fitting mask like CPAP. And as you can see on the graph, you have your PEEP, which is the pressure that is there in expiration, and that's keeping your alveoli open. And then you've got your IPAP, which is your inspiratory positive airway pressure, which is the pressure that you're delivering when someone's trying to take a breath. It's worth noticing that PEEP might be referred to as EPAP, so expiratory positive airway pressure, because, I don't know, it just makes it more confusing, doesn't it? So, invasive mechanical ventilation. This is, in the context of critical care, this requires an endotracheal tube, but some of you, if you've ever been in theatres or in A&E, you might have seen supraglottic devices like eye gels and stuff, but generally in intensive care, what's used is an endotracheal tube. So we'll just very, very quickly go through the anatomy of an endotracheal tube. So that's this thing in the middle here. So you connect the vent to this side. Here you've got a balloon, which is known as the cuff, and that inflates in the trachea, which is the windpipe, and you've gone past the vocal cords. So that blue bit is where you would inflate the cuff, and this is something on the right-hand side called subglottic suctioning, and you'll find it in some endotracheal tubes, especially the ones used in critical care, because they suck all the secretions that pull above the balloons. It's worth mentioning that there are the process of getting an endotracheal tube into the windpipe, the trachea, is called intubation, and there are specific guidelines for how to intubate a person with COVID. I'm not going to discuss it at the moment, but if you wanted to, stick a question Q&A and we can talk a bit about it later on. It is an aerosol generating procedure, intubating a patient. So ventilators. Ventilators can quickly get complicated very quickly. So there's a reason anaesthetists and intensivists take so long to train. But I just thought it'd be quite handy to point out a few different types of ventilators, because you'll likely see a variety in some critical care units. So on the left-hand side, we have a ventilator that you'd most likely see in an intensive care unit. In the middle, you have a transport ventilator, and they're quite handy. They're very small, and you will see them in places like resus. You will also see them in intensive care when you're taking a patient to a CT scan intubated, and you might even see them on things like HEMS, so the air ambulance as well. And over here on the right hand side, you've got an anaesthetic machine. So what anaesthetic machines do, they ventilate people much like all the other ventilators, but they can also give inhaled anaesthetic agents as well. And you might see them because actually, if there's a shortage of ventilators, the ICU sort of ventilators, sometimes people end up being ventilated on anaesthetic machines. So it's worth being aware of them. Okay, so let's go on to what we do in COVID. So the role of high flow nasal cannulas, CPAP and NIV depends on what guideline you're reading, unfortunately. There's some controversy surrounding the choice which to choose. So unfortunately, it's a case of there's no best evidence to favour one as opposed to the other. And so it's just a case of using your trust guidelines and whatever the clinician is deciding. But it's worth noting that there are people for whom invasive mechanical ventilation, so putting a breathing tube in and ventilating them on a ventilator, that isn't appropriate. So in these patients, this is the ceiling of care. This is the limit of what you will do for them, because actually putting them on a ventilator isn't the right thing to do. James has very handily mentioned already that there is now guidelines on proning patients whilst on high flow nasal cannulas, and from the Twitter sphere, that seems to be quite an effective intervention to do. So if you're wanting to have a look at it, I would strongly recommend reading those guidelines. They're, I think, a day or two old, so yeah, they'll smudge. So hypoxia in COVID, we've talked. What COVID does is it causes hypoxic respiratory failure. This is by far the slide that I'm dreading the most trying to deliver, so hopefully I'll be able to explain this clearly. But this is based on research that is, well, this is based on studies and papers that have literally just come out, and it's observational at the moment. It's report, expert opinion. It's not, unfortunately, everything, as with everything in COVID, doing a large study, we haven't had the time to do. But we talked a lot about ARDS. So we've talked about COVID causing leaky blood vessels and pulmonary edema occurring in the lungs, and then that collapses the alveoli and that impairs the gas exchange. And these lungs are really stiff, so they're not what we'd call compliant, so they're really thick, they're really hard to ventilate. But actually, this is probably only about 20% of the COVID population, according to the paper, which I'm going to put a link to on the next slide. There are a lot of people who are presenting, when you look at them, their lungs on CT, and when you check their compliance on a ventilator, they don't look like typical ARDS. And it's been suggested that this might be because there's a problem happening with the perfusion. So if you remember James's talk last week, and we talked about ventilation and perfusion, the problem might be on this perfusion side of things. And there's been a few mechanisms suggested, and one of them is that COVID might have, because it binds to the ACE2 receptors, which we mentioned very briefly, and affects the angiotensin system, which asks some chemicals that can cause blood vessel contraction, so vasoconstriction, or blood vessel dilation, depending on which angiotensin it is. Then it might be that COVID, because it affects this, might be causing areas of the lung which shouldn't be getting gas to get gas, shouldn't be getting blood to get blood going to it, and areas that should be getting blood, there might be some vasoconstriction. So this inappropriate constriction might be quite harmful, might be the cause of a lot of the hypoxia that we're seeing in COVID at the start. And these lungs are compliant, so they're not like ARDS lungs, they're not the stiff lungs. There's a suggestion that these lungs are easy to ventilate. They expand how you would expect them to expand. And in the paper, they've referred to this group of patients as those with the L phenotype, and those in the ARDS people group, they refer to as the H phenotype. So this is all very, very new, and the evidence and the studies about this are quite new. So I'd strongly recommend reading and watching some resources that are far more well informed than I am. So there's the paper is the first link, and if you're wanting to understand it, the second link is from the European Society of Intensive Care Medicine, and it starts talking about the difference in phenotypes and how that affects ventilation. Now, it is quite a complicated video. It starts talking about concepts like shunt fraction, but it's worth having a look at because it does kind of illustrate the phenotypes quite well. So let's talk about ventilating people with ARDS. So let's have a look at the CT scan. So I'll just get you orientated. So you can see here is the vertebral body, here is the heart, there's sternum just here, and you can see that these lungs don't look the same throughout. So at the bottom, the white is the fluid, and then at the top is black, and that's where the gas is. And the problem is that different parts of these lungs are easier to ventilate. So getting air into the fluid filled bit is really hard. These are really difficult to get air into, whereas in the normalish looking parts of the lung, it's quite easy to get air in. And the problem is, if you give a normal sized breath to these patients, the air will take the path of least resistance. So instead of going, it will tend to preferentially go towards the black bit, the good part of the lung. And this is a problem because this means that that part of the lung gets more air than it should have, and that causes overdistension, so overstretching of those alveoli, and that can cause inflammation, and that will worsen edema, and it can lead to fibrosis, and it's what we call volley trauma. So in ARDS patients, we should actually probably be ventilating them at lower tidal volumes, so the amount that we're pushing in, the volume of air that we're pushing in, that's what the tidal volume in is, should be lower than 6 to 8 mils per kilo of ideal body weight. So in the tidal volume recommendation is less than 6 mils per kilo of ideal body weight. So too big changes in pressure can also cause a problem. It can cause shearing forces, and that's called barotrauma. So volley trauma and barotrauma are things that we try and avoid in these fragile inflamed lungs that you see in ARDS. So this is known as lung protective ventilation. So LPV often results in high CO2. So if you think about your CO2 clearance, in order to blow CO2 off, you need to have a decent respiratory rate, and you need to have a decent tidal volume. Now, in this case, we're reducing the tidal volume, so as a result, the CO2 will creep up, and that's fine. Our body can deal with that for periods, but you'll naturally, if your CO2 starts rising, you'll want to breathe, and you find that people who are being kept permissively hypercapnic, that's a technical term, will want to breathe. And so as a result, you often have to give these people quite high sedation. The other advantage of giving high sedation is it reduces oxygen demand. And there's in some of the guidelines, it talks about paralysis, so giving drugs that will stop muscles completely, so stuff like cisatracurium. So PEEP prevents, PEEP is important in that if you are collapsing and opening your alveoli every time you ventilate them, then you can get shearing pressure, and that can cause something called atelectotrauma. But actually there is growing evidence to suggest that really high PEEPs might not be helpful in these COVID patients. And we've talked about proning. If you're still not sure about proning, you can ask a question. I would highly recommend you just have a look at Glenn's talk. So, mechanical ventilation, L phenotype COVID. So as I said, this is all very new, but this is quite an interesting picture. So both of these people are hypoxic, and both of them are COVID positive, but you can look and you can see the lungs look totally different. You can see the lungs here look pretty not normal, but they look good compared to the lungs on the right. And that shows you that there is likely a different process, or at least a spectrum going on. So in the L phenotype lungs, there's good lung compliance. So these lungs expand how you would expect them to expand. And actually the ARDS picture that you're seeing may not be there. So there is debate as to whether or not these people can be ventilated at normal tidal volumes. And there is suggestion that a low PEEP is very important in these patients, and that giving too high a PEEP can actually cause significant damage to the lungs. Like I say, this is all quite new, and I suspect there's not a consensus opinion on this. There's also a query for giving pulmonary vasodilators, so drugs that will dilate the blood vessels going to the lungs. So they're drugs like nitric oxide. Again, this is all brand new. This came on version 3 of this presentation, not version 2, so it's very, very new. So you'll be pleased to know that's the end of talking about advanced respiratory therapies. I'm just going to briefly mention other things that ICU do. This is not an exhaustive list, but it's probably worth talking about it just because, just for your awareness. So one big aspect of ICU support is cardiovascular support. So here you can see an arterial line, and arterial lines are quite helpful. They go through into a radial artery generally, and they will give you 2 bits of information. So you can take ABGs off them, so you don't have to put a needle into someone's radial artery again and again every time you want blood gas, so you can monitor their levels of oxygen and carbon dioxide. But also it gives you a almost second by second representation of someone's blood pressure. So it works on the same premise that actually kicking a tire does. So you can kick a tire and work out roughly how pumped up it is, and this works in a very similar way. Below it you can see a central line. So central lines can be inserted in the neck, so IJ in internal jugular, or it can go subclavian, or it can go in the femoral, so it can go all over the body. The reason these are important is that there are certain drugs that intensivists will give that are quite irritating if you give them peripherally. So one example of that drug is noradrenaline. So noradrenaline is what's called a vasopressor. So it causes blood vessels to constrict, and therefore it keeps your blood pressure up. So that's cardiovascular support. There's a lot more to it, but I just thought I'd mention these things as they're quite, you will probably, if you end up going onto an ICU, see these quite commonly. The other thing is renal replacement therapy. So the kidneys are really vulnerable to injury and acute illness, so you can get acute kidney injuries pretty quickly. And these are therapies that will help support it. And these are sort of day-long seminar topics, so I'm not going to go into the intricacies of renal replacement therapy, but you might see it referred to as CVV HDF or CVV HF or CVV HD, but I won't talk about what these all mean, but actually just know that if you see that, that's renal replacement therapy, and this is what one of the filters looks like. But the most important thing that ICU provides is time. ICUs support patients' organs in a bid to buy them time. A lot of what they do is not treating the problem, but it's giving them time. The other thing is the nursing staff. That's probably, the ICU nurses are probably the thing that makes the biggest difference to the patients in intensive care. And actually, intensive care is, for all of its fancy machines and intricate physiology, is about communication. Communicating with other specialties, communicating with relatives, and it's communicating with patients as well. Okay, so these are my last 2 slides, and I'm going to suggest that these are my most important 2 slides. So ICU has a huge impact on people. Being admitted to ICU can result in a long-term physical and psychological effects on patients. So when you're in ICU, in the first 10 days, every day you will lose 2 to 3% of your muscle mass because when you're critically unwell. And if you think about that, that's huge. And that includes the muscles that help you breathe, that includes the muscles that help you to speak. And you can see that people will rapidly become quite weak after being put on ICU. And the average stay for COVID patients is looking, in some areas, is looking at like about 14 days. So you can imagine this has profound effects on people. There's high rates of delirium in those in ICU and long-term psychological effects. And it can take many years to recover. And it's worth pointing these out because actually everyone thinks not everyone thinks ICU can be thought of as a magic bullet, and it's not. It has long-lasting impacts. And so you will probably see that intensivists are very keen to establish what people's physiological reserve was, so what they were like beforehand, and what whether or not they were able to, you know, walk around a shop and do their shopping and get dressed. And that's really, really important, because actually there is no point putting someone through intensive care if there's no likelihood of them surviving to a good quality of life. And so it's a really important thing for those of you who will make referrals to intensive care units. Please try and go about establishing what people's, you know, quality of life is, what people's physiological reserve is, because it makes the job a lot easier for the on-call intensivists. Okay, next point is rehab in intensive care is essential, and it begins as soon as someone sets foot in the intensive care. And it's really good that I think in our panel tomorrow we have Kate, who is one of the rehab nurses from Derriford. I would really suggest asking her some questions about rehab. And this is also important. Patients post-ICU often need greater levels of care on the ward. So when you leave ICU, because of all the things that I've spoken about, you aren't like normal other patients. They often require a lot more rehab, a lot more focused, good quality nursing care, and a lot of you will come across ICU patients if you are in clinical areas. And it's just important to realise that once people come out of ICU, the work hasn't finished. So I put some links, and the bottom link is a collaborative website from the Faculty of Intensive Care Medicine, the Faculty of Anaesthesia, Royal College of Anaesthesia, the Intensive Care Society, and the Association of Anaesthetists Great Britain. So this is a really important website at the bottom. So thank you so much.